All right, well, let's get started. Again, very warm welcome to everybody. We're excited to share with you the results of the Delaware rate study for home and community-based home health and personal care services. This session is being recorded and will be uploaded onto the DMMA website in the next few weeks. So please make sure you keep your mics muted. We will open it up to questions at the end, but along the way, if you have a question, please feel free to enter it in the chat and we'll make sure to address it. Before we get started, I'd like to hand it over to Drew Wilson if you have any opening remarks.
Yeah, good morning, everyone. I'm Drew Wilson. I'm the division director here at DMMA. I was planning on talking a little bit longer, but I'll be honest, I've been so sick and I'm still feeling it today. So I gotta stay very brief. And if I pop off camera, I'm blowing my nose and coughing into my elbow. So, but I will say that I'm here because this is important. And you've been phenomenal partners as we've been walking through this, and it means a lot to us. And so, I wanted to make sure that I made a point of being here. And so I'm very excited for what we're about to share today, and appreciate your partnership going forward. We're very hopeful that this brings some good information and some good leap-off points for us collectively. The services that you provide and these services are so vital to so many Delawareans. And so we're grateful to be able to shed some light and shed some information to help foster this for the benefit of just, again, so many people in Delaware. So we're grateful for you taking your time today. If you're watching and recording, we're grateful you watching it whenever you can. And looking forward to today's presentation, like I said, and our partnership going forward. So thank you so much, Amy.
Thanks, Drew. Well, and also, we do want to sincerely thank Drew and Michelle and Josh and team for their leadership in supporting this project, really for the open dialogue and transparency, and huge thank you to all of you who've been engaged and provided feedback along the way. We really appreciate it. So with that, let's start by kind of reviewing a background of this project. And if we, thank you. So just to review, this initiative was a part from DMMA as a part of the HCBS spending plan to conduct a review of the payment rates for specific services made for direct support professionals in the home health and personal care services. So we focused on 6 specific services as a part of this rate review. Also, as a part of this review, we reviewed Medicaid payment levels within managed care. We gathered input, as mentioned, from all of you, and then we analyzed publicly available data compared to that information that we received from you. The key outcomes of this project that we've achieved are to better understand the costs that you're experiencing to providing these services. We've developed benchmark rate ranges for these services that we'll be showing, to show a comparison to the current payments that are received. So if we look at the objective, really, we're trying to assess the reasonableness of the current reimbursement to direct support professionals who serve DMMA's non-IDD Medicaid population, primarily through the managed care program. And to do that assessment, we really looked at, did 4 different things. We calculated the average MCO payment rate using the claims data. We collected provider survey information that included wages, benefits, and other costs and operational items that you shared. We collected MCO negotiated rates by provider and service, and then we developed a rate range using this market data. So if I would start with just kind of some of the highlights, what we heard from all of you and the MCOs, from providers and the MCOs as a part of the survey process and feedback. If we look at the top part on the provider survey, we received 21 responses, and collectively there's a similar theme, workforce challenges, and that range from wages to having an ability to offer competitive benefits, and just feeling some additional struggles with trying to work with individuals given their having unreliable daycare and transportation. In addition, some similar themes in regards to just the growing costs to comply with regulations such as additional training requirements and EVV requirements. On the MCO side, we received information from all the MCOs. What we identified were some inconsistent billing approaches with using procedure codes that we've brought forward to DMMA to look at further. And we also saw just negotiated amounts vary by MCO, by provider, and by service type. And in looking at the different components that we utilize in building the rate ranges, what's on the screen are really kind of the four main components. First is the wage information, which is the biggest piece, how much the average wages are for various employee positions. Second component is employee-related expenses, ERE, and these are costs that relate from health insurance to state, federal taxes, and other employee benefits. We looked at other service-related costs, which include more indirect costs for things such as training, administrative costs, etc. And then we had additional assumptions that we layered in, such as size, productivity within the service, group sizes, units of service, and more. So all of these different components were leveraged and utilizing to build the rate ranges that you'll be seeing. So with that, I'm going to hand it off to my colleague, Leslie, to walk through the detailed assumptions, the rate range calculations, and of course, probably what people are most interested in, the results. So I'll hand it to you, Leslie.
Thanks, Amy. Everyone, I'm Leslie. And so the four components that Amy just walked through, we're going to walk through and show how it builds into the rates. So if we go to the next slide, we'll start with the wage calculation. And so when we first started looking at the wage calculations, we looked at several key pieces and put them together to develop the range of wages that you'll see when we start talking about the different services. And we started with the BLS data, which is a statistical database of all the wages nationwide, and we keyed down to just Delaware, specifically in the Mid-Atlantic BLS information. We also looked at, any legislative considerations, notably the minimum wage being passed in January of next year, which is coming very quickly. And we looked at different services listed in BLS that would best match the services that we're looking at. And so most of those codes would fall around the home health and personal care codes, but we also included considerations like nursing assistants, nursing, housekeeping, etc., to be able to see which services would best match with the wages that are showing in the BLS database. So putting all that together, we developed the wage assumptions, and we also used the survey data that the provider community shared with us to make sure that we're in line with what is coming through in Delaware specifically. Next slide. The second big component is the ERE estimations, as Amy mentioned. And so here again, we relied on the most recent BLS data that we could find at the time of pulling this information, and additionally looking at the IRS Employers Tax Guide to go through and develop these ERE components. And as you can see on here, there's several different components that we included in the development. And that goes anywhere from health benefits to state and federal taxes, workers' comp, long-term and short-term disability, paid time off, retirement contributions. Essentially what we get out of this is how much we would build into the rate model per year for ERE. And for part-time, we, depending on the service and at the lower bound, we built in $6,000 to $8,000 for part-time, and for full-time, it would be $12,000 to $15,000 per year at the lower bound. And for those of you that are not familiar with rate setting, when we develop these rates, we have a range of final rates, going from the lower bound to the upper bound. And so this is just on the lower bound. Next slide. And I apologize. The last slide was for all services, all of the typical suite of services. And then we also developed ERE estimations for self-directed services because we know that these services are handled just a little bit differently. And so you can see the differences are that we didn't account for health benefits or the long-term, short-term disability or PTO. And so at the lower bound again, the range we built in was about 2,900 to 3,100. We again considered all of these pieces we built up. We bumped up against the provider survey data and made sure that all the assumptions we're building in looked reasonable. And so here are some key quantitative takeaways from the data from the provider survey. We noticed that the average proportion of full-time DSP staff was showing approximately 36% across all services. The survey indicated that there is about a 12% wage difference for the average total wages, which includes bonus, overtime, and shift differentials compared to the base wages, meaning just your typical 40-hour-a-week base wage. The overtime wages were about 12% higher. The supervisor to staff ratio on average was 1 supervisor to 15 DSP staff. Across all services, the survey reflected about 20% of your DSP day being non-billable. And then we noted that the average cost for training or certifications was approximately $270 in cost per year and 4 days of training per year across all of the staff. This is an average for new and experienced staff. And then the average ERE per employee per year was showing about $6,000. And so if we had looked at the ranges in the last couple of slides, the ERE we're building in looks right in the range of where the survey says Delaware is experiencing. Next slide, please. So the remainder of the slides in this section are going to look very similar to this first slide here. So I'll walk through in a lot of detail what is on this slide and what information we can key into. But it is built by service, so you can see exactly what the different assumptions are by those 4 categories we talked about. So this is the slide for attendant care. We're looking at the wages. You have 2 wages for attendant care. We considered what would the DSP be paid at, and then also factoring a supervisor wage as well. And so for attendant care, we developed a wage range of $15.92 to $18.13. We factored in a supervisor wage of 22 to 31. And what we're listing is, again, that lower bound wage and then the upper bound wage. For ERE, we're seeing anywhere from 26 to 27% of the wages. And we assumed overtime to be about 10% of the wages. Other service-related costs, so our indirect costs, which include admin and program support. So for administration, on the lower bound, we have 10%. On the upper bound, we have 15%. And then assuming a program support of 5%. For training, the survey did reflect an average of 4 days, but consulting the Delaware legislation and rules around these services, we saw that the typical training is supposed to be about 75 hours. And so we built in 9 days annually for new hires, and then 12 hours for ongoing staff, which is about 1.5 days annually. And on the lower bound, we built in $250 for certification costs, and upper bound $300. In additional assumptions, we look at productivity. For attendant care, Something that we considered was an additional requirements for documentation. We adjusted productivity a little bit for accounting for those additional requirements. And so our productivity is 6.5 hours of 8 hours a day as assumed to be productive, meaning direct hands-on services with the member, and then the other 1.5 hours is for, you know, filling out paperwork and travel time, etc. Full-time portion of staff we're assuming to be 40%, and that was adjusted based off of the survey responses, seeing the high number of part-time staff was reflected in the survey. Turnover is 42%, and then for the supervisor to staff ratio, we wanted to be a little bit more conservative, and so we assumed a 1-to-10 ratio. And so we go through all those assumptions, we get to the rate range. We're looking at the lower bound for attendant care at $9.45 to the upper bound of $11.72, and this is for the billable 15-minute unit. That was a lot of information, so if you have any questions, please go ahead and put it into the chat, and then we will, of course, have time for questions at the end as well. So again, the rest of the slides are laid out this way just for ease of flow. And so again, I'll go through a little less detail, but of course, if you have any questions, please feel free to let us know. For attendant care self-directed, we built the wages, again, the same as the last slide, which is attendant care, $15.92 to $18.13. And for the self-directed services, we don't have a supervisor wage built in. ERE is 9% of wages. And then for administration, we know that that's paid separately based on the MCO contract, so we don't have admin costs in there. And then again, the same assumption for training. For productivity, we have 7 of 8 hours, and then the group size of 1-to-1. Again, for the 15-minute billable unit, our range is going from $4.98 to $5.66. Next slide, thank you. For home health aid, we have our DSP wage range from $15 to 86 cents to $19.30, and we have the supervisor range a little bit higher. The key considerations here for this service was that we wanted to account for the inclusion of skilled services in home health aid. And then the productivity was adjusted to account for any additional requirements for documentation. ERE is 25 to 27%, overtime again being 10%. And the administration and program support is consistent with attendant care and training as well. That ranges, the rate range from there is from $9.91 to $12.57 per 15-minute billable unit. Next slide. For chore, we have the wage range from $15.13 to $18.16. And the key difference here is the productivity was adjusted to 7 out of 8 hours. And just reflecting the less stringent requirements for documentation and other responsibilities outside of the providing the services. The resulting rate range is from $8.41 to $10.90 per 15-minute billable unit. Next slide. For homemaker, very similar to chore, so the range from here is $8.41 to $10.90. For companion, the main drivers of the different rates here is the range for the wages, most of our assumptions are similar or the same, because when we had looked at the provider surveys, it was really difficult to parse out all the key differences between the services specifically. And so you'll see here when you're reviewing this that the training and admin are very similar, and really what's changing is the wages and the productivity assumptions. And so for companion, our rate range lands between $8.77 and $10.88. Next slide. For respite, this is one of those wages where when we looked at the BLS codes that map with respite, it was landing below the $15 per hour minimum wage that's going to be reflected in January of next year. And so we bumped up that BLS wage from, I believe it was like $13.88 to $15. And so that results in the rate range of $8.36 on the lower bound to $10.88 on the upper bound. Next slide. The respite services are split into 3 different different service rates, and that was base respite. Now with PASA agency, the difference here is we incorporated an additional % of program support to support the additional requirements needed for this licensing. And so this wage is slightly higher at $8.45 to $11.02. And then the last respite service is the home health agency. This requires a little bit more licensing, and so we built in an additional percentage point for program support, but all of the other assumptions are the same. So the range for this service is $9.62 to $12.36. Next slide. For respite self-directed, very similar to attendant care self-directed, we built in the wage range. ERE is about 9% of wages for the taxes. And then no admin and program support or training, which makes the rate range fall between $4.69 to $5.66. So that was a lot of information. What we're doing on this slide here is we're summarizing what all of the lower bound and upper bound ranges are for these different services. What we did was we looked at where the utilization in our data fell. So you can see that the largest utilization here is attendant care self-directed, showing about 49.7% of the utilization in our data, and the next biggest being homemaker and attendant care. And we have some estimated impacts at the lower bound and upper bound using this, like the wage information, the rate range that we developed compared to what the MCOs had reported as the average rates that are being paid out in calendar year 24, which we trended forward to fiscal year 25 in order to make sure that our comparisons were on an apples to apples basis. So the next steps here, we will be finalizing the rate ranges. So most of the wages are finalized, but we did receive some information around attendant care self-directed that we're reviewing internally, and we'll be discussing with DMMA to see what we can do with that information. After the rate ranges are finalized, we will be publishing a final report, which will be shared with everyone. So that information that we just walked through laid out in that report. Next slide. These are just acronyms here, but we'll open it up for questions, and I see there's a few questions in the chat. So one of the questions I see is, how do you account for mileage expense at the federal reimbursement rate? the cost for travel, or the mileage expense is captured in the program support factor that we assumed at 5% for most of the services. The next question I'm seeing is what considerations can be given to the last minute cancellations by med waiver members, which can cause aides to often go without expected wages. I don't know if Amy or Holly have a response to that, but I think I might have to think about that.
Yeah, I think we can take that one back, but I think what the reference is to, missed appointments essentially, right? When a direct care worker is ready to deliver service, but a member may not be available to receive the service. So more like a vacancy or a missed appointment. But that's something we can take back and talk with the MMA about. Currently, there's not a specific factor targeted to that type of situation. Aside from the productivity, which kind of captures some missed service delivery time, but we can take that back and discuss with the MMA.
And we have another question. Are the slides available for download so we can study and reflect on this? So we have recorded this meeting, which will be posted to the DMMA website, and then we will share the slides so that you can digest the information, because yes, there was a lot of information here. Another question is, can you share any buildup of the admin G&A load? Same question for program costs, if that is a category in your work.
So I think for this one, for the administrative load, where it's ranging from 10 to 15%, that's really relying on the de minimis rule of, a standard percentage that's built into these types of rates. When there's not specific cost information available that could be applied statewide. So that's really where that percentage is coming from. And it's a range to try to capture different scenarios that may be in place across the state. And for program costs, that factor is really built in to capture other extraneous program related costs like supplies and travel and other items that are hard to detail out in every single situation. So that's really, adding that percentage add-on most accurately kind of captures those extraneous costs. Let's see, there's a question to go back to the acronyms. Let's see.
Are there any other questions about the information we reviewed today at this time? I see a question. Is there any documentation of maybe a comparison of these load factors used by other states in their work?
So we don't have anything prepared to share today. And it depends state to state. So sometimes that level of information can be available from other states, but recognizing that every state's waiver definition and service definitions are very different. And so doing the comparison is challenging, but there may be some information to glean from other states and those specific factors. I will say, Mercer has set these types of service rates in other states as well, and those are consistent with the rate levels that are built in.
And another question we have is, I see the T1005U2 as listed as a listed service code, which is not in the Highmark fee listed, the service is being denied in billing. Do you have any insight on this? I think that's a billing question for DMMA, but we can take it back and discuss with them and get back to you on that. Any other questions? All right. Well, if you do think of any questions, please feel free to reach out to us. And we will be publishing that final report as well as this information here on the website. So please, this is not like the end here. We will be continuing to keep communication open.
Thank you, everyone.
All right. Thank you for your time today.